Welcome, everyone. My name is Kira Sorrells, and I am the mother of two surviving 25-weeker triplets. I'm also the founder and executive director of the NICU Parent Network and one of the FCC Task Force core team co-chairs. I want to thank you all for joining today's FCC Task Force webinar, which is generously supported by Reckitt Mead Johnson and Draeger. We really are delighted that you have carved out the time to be with us today. You know, they say people make time for what's important to them. And we are so grateful that each of you recognize the importance of strengthening family-centered care practices throughout maternal infant health. So please, I see a lot of you already dropping in your name and your job role and your location. So please continue to do that so we know who's here. Would love for you also to share, what brought you here today. Next slide, please. So every webinar that we produce is dedicated to the NICU children of one of our family partners. And today's webinar is dedicated to Gavin, who is the micropreemie son of one of today's speakers, Mia Malcolm. I'm sure when she speaks, she'll share a little bit more about him. Next slide, please. The work of the FCC task force cannot be successful if we continue to work in silos. So we are really honored to include several esteemed national multidisciplinary organizational partners in our work, and we want to thank them for their participation and their support. Next slide. Our bi-monthly webinar series is generously supported by Reckitt Mead Johnson. This company has provided 120 years of science-based pediatric nutrition expertise that is focused on helping provide babies the best start to life. Next slide. Our webinars are also supported by Draeger, whose mission is to provide technology solutions that allow caregivers to work efficiently, parents to nurture, and infants to thrive. Next slide, please. The FCC Task Force has adopted the NEC Society's All-In Meeting Guide. And this meeting guide provides a framework for fostering equity and equality in healthcare meetings, creating a sense of belonging and community among healthcare partners and family partners. We utilize this guide to break down the hierarchy that is very common in healthcare. And one of the ways that we're doing that, you will notice that we will be addressing all of our guests by first name. And we also encourage open discussion throughout the presentation. So please, use the chat function and chat your thoughts, your comments, and add your questions as we go along. Next slide. With that being said, we also want to thank you all for being integral in ensuring that our webinars are a safe and brave space for all. We are united in that shared mission to strengthen family-centered care practices. And so we just want to remind everybody of a few quick things. First, of course, please mute your microphone when you aren't speaking. And if you do happen to be multitasking, as I know so many of us have to be these days, please turn off your camera. All questions and comments that are spoken and written in the chat should be respectful, non-discriminatory, and non-judgmental. Our goal is to build a more affirming, inclusive, and respectful community for all families and healthcare partners. And we want those with a passion for serving NICU families to know that they belong here. So please come with a growth mindset and be curious. One of my favorite quotes is from George Santayana, and it says, "Even the wisest mind has something yet to learn." We also want to honor the fact that many of the topics that we discuss here may bring up strong emotions and feelings for family partners and healthcare partners alike. You are not alone in your work, and your mental health is a key component to being successful in strengthening family-centered care. So if you find that you are having some of those strong emotions or sensations, please know that we are here to support you. You can send a private message directly to Morgan through the chat function and let her know that you may be struggling. You can also, of course, send her an email after the webinar. I mean, with a membership of over 1,200 people in this task force, we have an incredible network of trained mental health specialists and peer support specialists that we can connect you with. Next slide, please. The FCC task force strongly believes that being family-centered is not relegated only to the bedside, but it really is part of our all-encompassing organizational culture where family partners and healthcare partners are of equal value and importance. And we demonstrate this through our processes and our organizational structure. The task force itself is led by our core team, made up of neonatologist Malathi Balasundaram and Colby Day, alongside myself and family partner and our amazing project manager, Morgan Kowalski. I also want to take just a quick moment because she does not like to toot her own horn, but we do want to take a quick second to congratulate Malathi on recently winning the Stanford Pediatrics Advocacy Award for her work as a neonatologist at El Camino Health and founder and co-chair of this task force. And she was also recently promoted from clinical associate professor to clinical professor. So congrats, Malathi. We're just so excited that you really are our fearless leader in all of this. Next slide, please, Morgan. Thank you. So we also have an executive council of family partners that are made up of diverse birthing and non-birthing parents and caregivers. We are very grateful for their time, commitment, and expertise. And I'm really delighted to share that one of our newest executive council members is actually an adult former preemie herself. So it's really wonderful to have her join us in the council here. Next slide, please. Our Executive Council of Healthcare Partners is our multidisciplinary representation of the many clinical disciplines involved in the care of babies and families in the NICU. We thank each and every one of you for giving your time and your expertise so freely to do this work. Next slide. With that, I would like to welcome our newest Executive Council members, Fabiana Bacchini from Canada, family partner Lauren Ingledow, who is that adult former preemie I mentioned earlier, and healthcare partners Jessica Daigle and Lily Liu. Thank you all so much for joining us and being a part of our work. Next slide. We could not do all of this without our wonderful committees. The marketing and communications, newsletter, and advocacy committees are all co-chaired, as you can see here, by a healthcare partner and a family partner. Again, really putting into practice that equal representation of families and clinicians. If you have not yet joined a committee or would like to learn more, please, you can leave a note in the chat function here, or please send Morgan an email as well, and she will get you linked up with that information. Next slide, please. So just 2 months ago at our May webinar, I announced that we had over 900 members. And now in just 2 short months, we have grown to over 1,200 members across 48 of the 50 US states and Puerto Rico and 41 countries. So this is really exciting. It shows that this work is important, it is needed, and we are hungry to learn and collaborate. So thank you all again for just being a part of this. It's so important. Next slide, please. So this is actually our 15th webinar so far. If you want to take a minute to look at the past sessions that you may have missed, you can find all of this on our website. Morgan has continuously compiled our webinar database, and it is located under webinars and resource tabs on that website. And our data has shown that the centers who are sharing our webinars and our monthly newsletters with their team members are having more success with their family-centered care work in their units. So please share the work and the information freely. Next slide, please. So each month we put up a poll based on questions posed on the listserv, and this month's poll is specifically for those who have been successful in implementing FCC in their units and has to do with administration and leadership buy-in. So please take a minute to scan that QR code, and of course Morgan is so good about sending out follow-up information after, and we'll include that as well. But these polls really do help us share those best practices so that successes can be repeated and units can avoid starting from scratch every single time. Next slide, please. This year, one of the things that we implemented is the monthly office hours, which is an informal gathering online where we share our challenges and successes. These discussions, I feel like, have just gotten better and better each month that goes by. So please make a note to join us on July 5th. Morgan has popped in the registration in the chat box. These office hours are, again, facilitated by a family partner. This month will be Jamila Jackson, and a healthcare partner this month, Aida Simonian. And I'm so sorry if I did not say that your last name correctly. Next slide. So this year we are in phase 4 of the task force objectives. And that is that we are working on benchmarking FCC NICU measures. We have collaborated with our executive council family partners and created a comprehensive red cap survey that includes 7 categories that you can see listed here on the left side of the slide. What we need is for your units to participate so we can begin to gather robust data that will serve our babies, families, and our healthcare teams. And I will be transparent. This is not a simple 5-question survey. The number of questions is listed in the parentheses after each section. But if centers are interested in collaborating with us, please let us know. It is, like I said, it's comprehensive. Your center will receive an immediate score upon completion. And then once the entire study is completed, your unit performance will be benchmarked within participating NICUs. Of course, all identifying data will be kept anonymous. So if you are interested, please email us your clinical or QI leader information so we can share the survey link and PDF. A grant from PAC USA has supported this study. And this really is the cornerstone of what we are all doing here. We don't just want to say that we're doing FCC or that we're good at FCC. We want to be able to demonstrate that in a measurable way. I mean, you count what counts, right? And this counts. So we really need you to step up and let us know if your unit would like to be a part of this pioneering cohort. So before I turn it over to Malathi, just another quick reminder to please turn your camera off if you're multitasking, mute your microphones, be curious, and thanks for being here. Malathi?
Yes, thank you, Kira. Oh, thank you for the surprise wishes, and I really appreciate that. And I'm so honored to work with so many great people. And thank you, everyone, for all your wishes. And it's my pleasure to introduce first speaker, Paige Church. And Paige Church has completed her pediatrics trainings at the University of Chicago, focusing on inner city medicine and complex care. She then completed a combined fellowship in neonatal perinatal medicine and developmental behavioral pediatrics at Tufts University School of Medicine in Boston. She is board certified through the American Board of Pediatrics in both neonatal perinatal medicine and developmental behavior pediatrics. She is now at Beth Israel Deaconess Medical Center and Boston Children's Hospital, where she works as a neonatologist and developmental behavior pediatrician in the growth and developmental support program called GRATS Clinic. Her academic interests include developmental care, long-term outcomes of babies who were cared for in the NICU, systems of care, spina bifida, and disability. I enjoy working with Paige on the Grievance Planning Committee, and I have listened to her insightful talks a few times. I look forward to this talk on families as neuroprotectors, my favorite topic. And Paige, please take it away.
Thank you so much. And thank you for this awesome invitation. I'm so excited. I'm just trying to share my screen, sorry. There we go. Share. Great. So now hopefully you can see my slides. Yes? Yes,
Yes,
okay, great.
slides, but
Let me
not
just,
the presenter view.
yeah,
It's still
there
in
you
the
go.
presenter view, not the slideshow.
There you go. How's that?
Yep, good, perfect.
Awesome. Okay. Thank you so, so much for this invitation. I was tasked with talking about families as neuroprotectors, and that's such an awesome topic and a huge topic, and also a topic so near and dear to my heart. So just quickly, in terms of disclosures, I have nothing to disclose. I would like to acknowledge the land, at least that I am working on today, which is the land of the Massachusetts, Pawtucket, Wampanoag, Nipmuc peoples, and express my respect and appreciation for the past, present, and future. This is actually on a hike I do sometimes with my dogs, and I just love it. It's just a beautiful little thing you find in the forest, which I think is great. So my goals today, what are we going to do? What I hope we're going to do is we're going to review very briefly what we know about the long-term outcomes of premature birth. We're going to talk about the impact of the NICU environment on babies and families, and where I see strategies that are maybe more facile to implement to build families as neuroprotectors. So what we know about the ICU and the babies that are entering the ICU is that these beautiful little humans come in to our ICUs with brains that are incredibly primed to be learning and to be receiving the environment. And that certainly is something we've learned over the years from the Graben's environment, is the profound effect that the environment has on these brains as they learn. So we know that our babies' outcomes are driven by obviously the biology that they come with and their genetic inheritance, but then a huge piece of this is the environment that they're exposed to. And in the NICU, that environment includes pain, stress, and separation. We also know that our children, when they leave the NICU, have possible outcomes that have been deemed to be major or significant outcomes, and then minor. And I really don't like dividing them because I think they're all really important. I will just pause to say that many of the photos you're going to see in this talk are from the American Academy of Cerebral Palsy and Developmental Medicine. They are publicly accessible, and they are part of a contest called the Life Shots Contest, which is where families take photos of their children and send them in, and they line the pathway as you walk into the annual meeting in these huge posters, and they are awesome celebrations of children and how beautiful they are. What we know about children who have a history of premature birth is that they can present with early findings that may be associated with significant challenges across their lifespan. And those early findings include cerebral palsy, vision or hearing differences, challenges with learning, or autism. Depending on the outcome you are looking at and the gestation that you are looking at, these numbers can range from anywhere from 1 to 25% of children may experience these outcomes. Much more common, and yet not perhaps as significant, and certainly that do not present as early, are these things that have been referred to as minor morbidities, and they include challenges that may involve behavioral challenges with executive function and attentional regulation. Mental health, anxiety, and depression may be experienced. Learning, particularly how they process, and their visual spatial learning can be affected. Motor skills in the absence of cerebral palsy can be affected with developmental coordination disorder. Graphomotor or visual motor skills can be affected. Language, both what they understand and what they speak, can be affected, and the sophistication with which they do both can also be affected. And then socio-emotional skills and social communication. So we know that the children leaving the NICU have a pattern of outcomes that definitely is characterized by strengths and challenges, and that they are phenotypically somewhat different than term children. We also know that the NICU is a place of intense emotions, and this has been framed by John Lantos, who talked about the emotional cauldron of the NICU. I love this cartoon. This was drawn by Jack Maypole for me when I was trying to describe what I thought the NICU was like, in terms of, we're all pouring into this big cocktail or this big stew, our hopes, our biases, our fears, our understanding of the situation, our insights. And we're doing that as providers, but the parents also come and they add their hopes and their biases and their emotions and their understandings to this cocktail. And it really does create an environment that can be very challenging, particularly for parents. And this quote is from Michael Heinen, and it is probably one of the most eloquent quotes I've ever read about the NICU. Distress is the companion of everyone in the NICU. This is a spaghetti diagram that Virginia McLaughlin did several years ago now, kind of looking at specifically what families bring into the NICU and what they experience in the NICU. And certainly this does not encompass all of it, but it's a really nice visual to understand what parents are coming in with and what they're experiencing in the NICU. And that the sources of their trauma include this exposure to judgment and shame. Kate Robson talked a lot about parenting on stage, feeling like everyone's watching you, coming in with pre-existing challenges that may have nothing to do with the NICU, but are added stressors that are going to constantly weigh on these families. It might be a lack of support. It might be mental health conditions that pre-existed this pregnancy, other social stressors, prejudice, fatigue, families trying to work, come in and see their babies, the alarms, the exhaustion. That certainly changes how you process information and how you learn and how you respond to trauma. A feeling of a lack of control, not having that sense that you are in control of your baby's future, that loss of that role, lack of or perhaps not appropriate communication. I had an early home visit just this morning with a family, and the father was very upset over a blood transfusion, and I'm fairly confident that we got consent, but he didn't remember or understand what had been talked about. And so there's a lot of things happening for these families, living with fear and tension, being isolated, not being able to have support around them. And this identity crisis, that this loss of the dream of the parent and the child that they thought they were going to be, and it may provoke stressors within the relationship. So in this ICU setting, all of this is happening in the background for our families. And what we know is that this results in families having profound effects from the NICU that can lead to, upwards of as high as 40 to 45% of parents leaving the NICU may experience mental health or post-traumatic stress as a result of being a parent in the NICU. That's really high. And that would include families that endorse symptoms that are significant enough to flag out on questionnaires. It doesn't include those families that struggle with problematic coping, but not necessarily enough to count as a disorder. So I think this number is conservative. We also know that getting into the ICU, there are a lot of barriers. And these barriers include traffic, which is something we all experience. I experience it every day I drive into Boston. We have the barriers of fear around infection. COVID is still very much an active thing for many, many people, and is lovely showing itself again this summer. There's the financial barriers, the cost of parking, the cost of gas, the cost of coming in, time off from work, getting childcare, having someone else help you take care of your other children. Many units have closed themselves to siblings, and that makes it really hard for families. And then there's the NICU culture, not understanding who we are, what we do, why we do what we do, the language that we use. All of this stuff contributes to why parents may not want to come in. And as Mia said, and she's going to talk a lot more shortly, and every time I talk to her, I feel like I learn. And this was her just talking freely as we were planning our talks today and our slides. And her quote was, "You are going to work at your job. I am in hell." And so we sort of forget that our standard culture of just, who's going to get coffee from Starbucks at what time, and we have radiology rounds at this time, this isn't normal to anybody but us. And so for families, that culture can be very overwhelming and very frightening, and contribute to parents finding reasons to not want to come in because it's so stressful. The problem is, and the challenge is for us as neonatologists or as providers in the NICU, is we don't really just have one patient here. We actually have two. We have the infant and we have the parents. And it is foolish for us to think that we don't have two patients, because we're three, because we really do. And so what we have to focus on, and we've done such a good job with our science on developing nutritional bundles and respiratory bundles and all these bundles to help our babies grow. And we haven't come nearly as far at helping our parents to grow and recognizing that our parents are premature as well. More often than not, there are going to be term children that have come into the NICU, and I apologize if I am appearing to not give them the same credit or attention. The lion's share of the patients that I follow do have parents that were born prematurely as well. And or for those who are term, it's parents who unexpectedly end up there, and it is a traumatic entrance to parenting. So we need to grow these parents, and how parents cope with this trauma of being in the NICU is that historically they tend to intellectualize. They want to learn, they want to understand what's happening, and they will go on things like Google and books and try to come up with information so that they can feel that they are empowered. And we hear this from time to time from colleagues. Oh, they've been on Google. They're trying to understand where they are and who they are. And the other important observation, and this interestingly is in a textbook that has nothing to do with neonatology and has to do with developmental behavioral pediatrics. So my other life watches what we do, and yet we never really pay attention to what they're writing about. But I thought this chapter on NICU was so rich because it talks about this concept of premature parents, but also this idea of attachment competition. Feeling like parents aren't attaching to their babies because they can't do the care quite like we do. They aren't able to provide, they aren't able to feed their baby quite like the NICU team can. They aren't as capable of handling, the crises that happen. And so parents then feel that they're not able to attach, or they have to step back, and that the providers become the more attached ones to their babies. And that's really, really unsettling because it's not our baby, and it's not supposed to be our baby. So we have to pay better attention to both of our patients, rather than just the baby. So how do we do that? There have been a lot of really interesting papers and approaches to this, and I am going to hit on some of the high notes and talk about the ones that I think are more easily implementable. I think the foundation of being more family-centered and encouraging families to come in comes from Mary Coughlin's work with trauma-informed care. I have learned so much from Mary over the last, I don't even want to say how many years, because it would make me sound like I'm not 12, like I want you to believe I am. But really at the core of this is this idea that we build trust, that we empower families, that we collaborate with them, we offer them choices when possible, and we make them feel safe, and we give them an environment that feels safe. And then from Michael Heinen's work and others is this idea of how do you build an NICU that is family integrated? And that has to include developmental care for families, mental health, peer-to-peer support so that they can learn from the wisdom of each other, staff education so that we're more aware of what families need and what we are doing and how it impacts them, post-discharge follow-up, which is the land that I live in more often than not, and then for those who do experience loss in the NICU, the palliative and bereavement care that they need as well. So starting to look at this, how do we accomplish this? How do we start to provide with families, providing them with an opportunity to feel like they can be in the NICU and be understood? And this was some interesting work done by Maya DeHaan and Carol O'Brien, looking at families' experiences and staff and clinician experiences in the ICU with just how we share who they are. So parents' experiences involves that there's a revolving set of clinicians, everyone is coming and going, that results in broken telephone, that the parents have a desire to control what we understand about them, understandably. And interestingly, clinicians also want to have that control over making sure that the story is shared. Unfortunately, however, that story can get broken as we hand off to each other. The impact of relationships on how they feel, and for clinicians, it's us making relationships, the impact of their personhood and personalizing their care. And so Maya has translated this into a really, really lovely tool that is available on Epic, and I think has the potential to be a very powerful way to make families feel more centered and more involved in our day-to-day care quickly. And what it is it's something called the family snapshot. And it seems so simple that everyone is like, well, why are we not doing this? Or this is so simple, of course we do this. And I would argue that while we think we are, it's really hard to find this information. In every ICU I've worked in, when I've been asked to consult a baby or a family about developmental issues, the information about the family is here, and it's there, and it's this place, and it's word of mouth, and it's on the handover, but it's never in a centralized place that I can scan in 3 minutes and get a sense of who this family is. What are their values? What's important to them? How do they see this going forward? What are their supports that they have? Are there important religious beliefs that I should be honoring? What are the things that are keeping them from spending time with their baby? What are their preferred pronouns? All of these important things are in one place, and I can scan it in 3 minutes because, let's be honest, everybody's time is so precious and so protected and so hard to encroach on adding things. This provides an opportunity for families to share what they want you to know about them up front, and then we can find it in one place, and it can be consistent and represent what they say rather than what I thought they said, but I was tired because I hadn't slept, and then I thought I wrote it down right, but maybe I made a mistake. This just lets it be in a place where they can control that narrative and we can understand them more effectively. I think another key fundamental piece of helping families feel that they can be a part of our care and that they are the center of our care is we have to pay attention to what we say. And I'm not going to get into this too much because Mia is going to hit on this a lot more than I am, but to tee up that what we say has profound effects on our families and what they understand in the ICU. And our language shapes realities. And this is based on developmental theory around how humans learn. And our parents are coming into the ICU learning a whole new language. This is not their normal place. This is not where they know. This is not their workplace. And when they hear our language, severe, risk, bad, impairment, abnormal, when we talk about all of these things, first and foremost, they may not resonate with what they interpret these things that we're talking about to mean. Certainly everyone would agree that there's a risk of an infection, and that would be a negative thing. We don't want our babies to have an infection. But is there a risk to having a child have a developmental outcome that might be different, but that child could still go on to have friends and all the important things? Many families would say, no, I don't see that as a risk. I see that as a possibility. My child may have this, they may not. So what we say shapes their realities and their understandings, and it is really important that we're very mindful of how important our words are. And Mia is going to talk more about all of the things we say. You know, failure to extubate. Is it really a failure, or is the baby developmentally not ready? All of these things shape our realities. And then shifting to more tangible or perhaps more, you can check the box and say, yes, we're striving for this or we're doing it, more implementable strategies. I think it's irrefutable to talk about kangaroo care. It is crazy to me that we still are talking about it after all of the data we have. This is a picture of a child's monitor. And this part of the monitor is when the child was in their isolette. In theory, safe in the NICU, but certainly experiencing a lot more cardiovascular and cardiorespiratory instability. And then this side of the monitor is when the child went skin to skin with her father and was much more stable and calm. We have good data that kangaroo care is very effective. And this is lovely. This is twins. It's beautiful when you can say, well, you won't even just do it with one, we'll do it with both. But we also know that the long-term data for this is profound, and it is long-term. It is not toddler data. We are talking about adult data, where we see differences in brain architecture with kangaroo care duration and gray matter volume, basal nuclei, cerebellar, and white matter organization. And while that's lovely, and Stephen Miller and I have healthy arguments about, well, that's nice, your pictures are beautiful, but what does this translate into functionally? Functionally, these children exposed to kangaroo care had measurable differences in their IQ, the way parents behaved and parented later on in life, that there was decreased school absenteeism, and there was less hyperactivity and aggressiveness. So there is a functional impact to having this incredible opportunity to snuggle with parents. It is not just a feel good. Despite that, we still find that families are struggling with how to help staff see the importance of this. And this is a beautiful paper from a team looking at the comparisons of a parent versus a nurse on the importance of kangaroo care. And you can see that there are significant discrepancies between the parents' perception of how important and how quickly it should be done, and the staff's perception of how important and how quickly it should be done. And I know some of this relates to staffing and concerns around extubation and the trauma of this, but it really is pretty compelling that the data shows that these children do better when they are kangarooed. We also know that these children are exposed to many, many, many procedures and moments where they are touched and handled by providers who are not their parents, and whose hands feel, touch, smell differently than the hands that they will and have come to know as their parents. And that this too has an effect on how these children's brains grow and learn, and can be minimized if we leverage parents more effectively. One approach that has taken a exciting approach to taking parents and really bringing them back into the ICU and making them an integral part has been Carol O'Brien's work with the family integrated care work. This is actually a photograph from family integrated care at work. And this was a parent presenting her own child 2 rounds. She's wearing a gown because she was kangaroo carrying. And so she had to throw something on so she could come out and provide the report on her child. What I can tell you is that this young parent went from being incredibly fragile and shy and uncertain about her baby to being very empowered and very confident and knowing about her baby. And it didn't happen overnight. It took time and took growth. We grew her as a parent. And so this is powerful. I do think it needs to be individualized, as Annie Janvier has raised as an important consideration, and not every parent can do it the same way, and we need to adapt just like we do for children. And what we have found is that when we do provide this care, that these children are as safe as they would be with their parents. We did not find that infection went up when we looked at this in a randomized control trial, and that the babies did go home slightly earlier and breastfeeding more readily. And when we looked at these children later in life, and this is only 18 to 21 month data, so this is very, very short early data, but what we did find was that it doesn't take away the possibility of if you're going to have cerebral palsy or not. We can't, that can't be what the expectation is when we do a lot of these studies, but rather what we did find is that the children whose parents were at their bedside providing more of their day-to-day care demonstrated greater regulation capacity than the children whose parents were not able to be present and were not participating in PHI care. And then there's this quagmire of developmental care, and there's so many different perceptions of what that is, what that looks like, you know, how effective is it effective, is it not? And when you look at this, one of the greatest shortcomings is that there's such different strategies that are implemented, and then measurement tools to measure its success. And so when we've tried to look at it across different approaches and tried to analyze the data in a larger way, it really has proven to be quite hard to do because everyone's approaching it slightly different. That doesn't mean that it isn't effective, and it doesn't mean that we shouldn't do it. But rather, I wonder when we do our research if we're asking a fish to climb a tree. I think that what we're looking for and what we're measuring is important, but we need to be a little bit more mindful about how we measure it and perhaps how we implement it so we can get better measurement tools. And I think that an exciting step forward for this is going to be the work that comes out of this with this protocol that was just submitted, looking at trying to understand through a scoping review protocol of what we can do with family-centered care. Another step, and I'm going to start to get a little bit more uncomfortable, maybe. I think kangaroo care and PHI care are becoming more and more, kangaroo care should be standard, but PHI care is also becoming much more common. This is a little less common, and yet I think it is so important that we consider it. We did a small trial at Sunnybrook in Toronto called the STEP program. And what this was, a key element of parenting and growing parents is to make them feel like they are capable. And that is very hard to do when you're in an NICU environment with a door or a curtain between you and an expert who knows your baby and can care for your baby better, and I put that in air quotes, than the parent feels that they can. What we ended up doing was having parents take their babies for walks in strollers. And this parent that's photographed here was the parent that really pushed for this and spearheaded this and really just drove it home and would not relinquish. And this parent had gone from a very shy and anxious parent of a 385-gram baby to a very, very confident parent who we oftentimes weren't so sure we knew where she was. But the point of it is that just letting these parents do something that is normative, taking their babies for a walk, making decisions for their babies that didn't include the team and the nurses, demonstrated that these parents found that they were more connected to their children and more confident leaving. I was now in charge of my child, and that it was up to me to decide how safe or not safe, and to give myself a little bit of self-confidence. And I think that's important for moms especially when you're getting closer to discharge. It's the lack of self-confidence and knowledge in your own capabilities of being a mother, because it's stripped from you right at the door. So this program lets parents take their babies out in strollers, sometimes to start with a parent nurse supervising them or taking them and working with them, but often as the parent demonstrated greater capacity and was closer to going home, they did it by themselves. And it stretched that umbilical cord of the NICU to the parent and let them start to experience parenting independently. And in terms of mental health, I think that this still has a long way to go, and I think many units are still struggling with exactly how to handle this. One approach that I think has shown some interesting positive results and possibilities is something called acceptance and commitment therapy. One of the greatest challenges in the NICU is parents endorse anxiety, and that is appropriate anxiety. Unfortunately, for anxiety that is disordered or abnormal, the gold standard approach is to do cognitive behavior therapy, where you address your anxiety and you learn that it is based in distorted thoughts, and then you work through it. Acceptance and commitment therapy merges cognitive behavior therapy with values and mindfulness, and really helps parents acknowledge that what they're worried about is real. It is very real. So you can't say it's distorted and work through it. But instead, how do you put what's important to you and your values in the front of you, in your front windshield? And how do you push the worries that are real to just be to the side, so that you can still see the joy and the day-to-day experiences of having a baby in the NICU or not? The data is for children who have autism was where this sort of started from, and it demonstrated that for families of children with autism, there was a very positive effect to using ACT. The data for children who have special healthcare needs is a little more unclear, but we are currently looking at it in the NICU environment to see if it can be helpful for families as they navigate their experience. And after discharge, well, I'm not going to get into that terribly much. And I think, frankly, in the NICU, I think more screening of parental mental health is not only, it not only should be happening, it is essential, because we can't build on development if the families are unstable or depressed. So I hope I haven't gone too long, because I want Mia to have full time to talk. But what I want you to take away is that our families are our first wall of defense, and we need them so desperately to help us take care of their babies. The problem is that they are premature parents too, and we need to grow them. And in order to do that, we need to create an environment where they feel safe, where they feel like they can explore their parenting at the point in their own development that they're at, and that they can develop their own capacity as parents to make their own decisions. And from that, then, healthy, beautiful attachment can bloom. Thank you so much. And I don't know if I'm handing it over to Mia now or if I am staying on, but I want to also give, I want to thank my teams that I've had the privilege of learning and working with at Sunnybrook, at Children's, at the BI, at Tufts. So thank you. And my own family, thank you. So I'll stop sharing.
Oh, that's wonderful, Paige. Thank you for sharing that. I love that takeaway slide, and I just wish everyone can take those points and take it to their unit and start implementing that. Parents are premature too. Thank you. So some of them asking, can we steal that quote as
steal the quote? Parents are premature? Sure. Not mine. It's from a developmental textbook. I have to give credit.
Okay, thank you. And anybody has any questions? So we have 7 minutes per page, and I do have some practical questions. I can start with that. And
yeah.
The family snapshot tool, is it available to other units to use? Is it available in electronic health records?
Yes, I'll put in the chat. It's Maya Dehan is the brilliant, lovely human that came up with that. And it was so obvious when she talked about it, and I couldn't believe it had never been thought of. It just is a place where everything about that family that they want us to know is there. So it's not like you're walking in and having to say, okay, so remind me, if it's a different family, I personally came into my family and my child in a different way. We were not biological parents, and it drove me crazy to have to tell that story every time I saw a provider. Wouldn't it have been nice to have it in one place? I am her, parent. This is her other parent. This was her biological parent. This person is only involved in this way for these decisions. Like, these are really important conversations I didn't want to have again and again and again.
Thank
So,
you. So I can reach out to Maya and
yes,
ask
Maya
her.
is brilliant.
Okay, thank you. And anybody has any other question? The next question I have is, how did you get a buy-in from the risk management for the families to take their babies, go for a walk? I'm struggling.
That was impressive.
Help me.
That was impressive. I will tell you, this is the power of parents. This woman was like maybe 80 pounds soaking wet. I mean, she was tiny, her baby was tiny, the whole thing was a tiny package, but it's like those Tides pods, so concentrated. You couldn't avoid this woman. She kept pushing and pushing that she needed to take her baby for a walk. She had been in the hospital for 5 months, and we just kept pushing back to the hospital and saying, we had an administration that believed that parents were equal partners. And so when you come to it with that kind of a mindset, there's already a lot of grease in the wheels to make things happen. And that was, we felt strongly. We said, if we're going to send these children home in 4 days, really, we should be sending them out to practice what it's like to be away from us. And if they're 100 feet away and that's not making us comfortable, we have no business sending them home. And so we were able to work through it. And what they wanted was they wanted an infection control protocol. We had to write one up. We had to write, they had to be, there was a consent process. I'm like, well, they're consenting when they take their baby. And CPR training. And I used it as a carrot to get people CPR trained. And so we had parents leaving that were more capable and had more training than they were getting before because they were incentivized to take their babies. And I will tell you, during COVID, it got shut down like everything. But parents, again, demanded that it restart. And I took the first mother out during COVID, and there was a new infection rule that we had to follow. And it was raining, and I didn't really want to go. And, I was like, this isn't the greatest day. And she kept saying she needed to feel the air on her face, and she wanted the baby to have fresh air. And so we went, and I looked over, because we got outside, and I was like, okay, it's raining. Like, let's turn around and go back. Like, I don't want to get all wet. And I looked at her, and she had tears running down her face. And she just kept pushing her stroller into the rain. And I was like, I'm out here as long as you want. Like, that small thing meant more to her than anything I could have done for her in ever. And it's just so normal and beautiful. And during COVID, when the people weren't allowed in, I was under no illusion. I knew that the grandparents were pulling up. I'd watch the cars come in, all of a sudden you'd get them to the place where they'd be in the garden, and you see 2 cars come, and these older people like booking it over to see their grandchild. This is what parenting is supposed to be. And if we're going to send these kids home in a matter of days, there is no reason in my mind that they shouldn't be taking their baby out for a stroller walk as a practice run with their informed consent. If we don't trust them to know what's best for their child, and we don't trust ourselves to know that they're almost ready to go home, then we shouldn't be sending them home.
Yeah.
So.
Thank you, Paige. I'm gonna start crying. Thank you for sharing that. And someone asked if you're okay, if you're willing to share your protocol or policy to take out infants out of the NICU. Okay.
Yep. I will say that, to give Sunnybrook credit, that was Sunnybrook at the University of Toronto, and my God, were they ever progressive. Great hospital administration that was willing to play ball.
Okay. So with that, I can hand over to Morgan, and thank you, Paige, for your wonderful talk and accepting our invitation.
Thank you for the invitation.
Hi, everyone. Thank you so much, Paige. Our next speaker is going to be Mia Malcolm. She is a family partner on our executive council here at the Family Centered Care Task Force. She is the NICU parent of Gavin and an expert facilitator of all things diversity, equity, inclusion, and belonging. Mia truly has a long and shining CV, but she insisted that today is about being Gavin's mom. And so with that, Mia, I will let you take it away.
Thank you, Morgan. I just want to say that following Paige right now feels like not the right thing to be doing, but we are going to do it, and we are going to power through, and it's going to be amazing. So I will share my screen, and we will get started. So again, I'm Mia, I use she, her pronouns, and I'm gonna be talking to you all today about the power of effective communication in the NICU. So before I get started, I too just want to do a land acknowledgement. I think that they're really important to do. There are a lot of people who have sacrificed many, many things in order for us to be able to do the things that we do. So here in St. Louis, which is where I am, that means acknowledging the indigenous people, the Cahokia, Illinois, Mississippian, Osage, Miami, and Sioux people. I recognize them for and express gratitude for, like I said, the sacrifices that they made for us to be able to live the way that we want to live, work where we work, and do the things that we do. And I also always try to do this as a way of acknowledging the genocide that they experienced and the continued harms that they endure on these lands. So there is that part. So again, I'm going to be talking about language and storytelling because I love to tell stories. And I would love for us to just think about the words that we use and the stories that we tell, the impact that they have on families and how we can adjust those things because we know that communication is the cornerstone of effective patient family-centered care, and that's what we should all be striving for. So we will start with words because they have direct and indirect impacts on people. So we are going to start there. This is my son, Gavin. You guys saw a little kind of collage of pictures of him a little bit earlier, but G, which is what he likes to be called now because he's a big kid. G was, and according to my mom, he still is a micro preemie. He was born at 24 weeks, 15 years ago, and we spent 268 days in the NICU at St. Louis Children's Hospital. His journey, his experiences, my experience of his experience, is what brought me into the work that I do with advocacy and EDIB in healthcare. So today I'm just going to talk to you guys about G's journey and how I experienced his journey and just the words and things that I heard that had a really profound impact on me, and maybe how we can do a little bit better to support our families through language. Okay, so I want to ask, and you guys can put in the chat, if any of you all who are clinicians, physicians, nurses, OTs, PTs, speech therapists, whatever your role is in the units, if you remember the first time that you called or implied that a patient was a failure. So for me, I obviously remember the first time that somebody told me that G was a failure. I journaled every single day that I was there. I have like 15 different journals just full of stuff from his NICU journey. So believe me when I say I really do remember the day and where I was and what was happening that day. He was 5 weeks old, so he was about 29 weeks gestation, and it was on a Wednesday. And the team decided that they were ready to extubate him and like, let's see how this works. And they took his ET tube out, and Gavin said, no, thank you. And he coded immediately, big time code, and it was not great. But they were able to get him reintubated and settle him. And his attending turned and looked at me, and he goes, well, he failed that. And I was just like, oh, okay. And so for the next like couple of weeks, next 3 weeks or so, I listened to how he had failed over and over and over again. And over the next 9 months, I listened to all of these endless stories about the medications that he had failed or the interventions that he had failed. And I think that in that moment, I just remember thinking like, he's 5 weeks old. Like he's only been around for 5 weeks. How is he the problem in this situation? Like, how is he failing something that's been around since like 400 BC, right? But I think the biggest thing that I was feeling and thinking in that moment was that he was a failure because I had failed him, right? I have failed to carry him, to keep him safe. And now look at what happened. Look at what I've done to him. So even to this day, every time I hear the word failure associated with him, it's really hard for me because it not just makes me feel bad about what's happening with my child, but it makes me feel bad for what I did essentially to my child. So next up on the list is this idea of misbehaving, right? So imagine me sitting in Gavin's room one day and he is having just a day, right? Like he is the kid who is having all the Brady episodes in the world. Like he was Tom Brady. He was like an MVP Super Bowl champion of Brady's this day. Like he was not letting up on these Brady episodes. And his nurse like sachets in and she goes, man, he is really misbehaving today. And I just like in my mind, I'm like, does she think he's doing this on purpose? Like he's just doing it to annoy her. Like he got up that morning and he's like, watch what I do. You know, let's call her, watch what I do to Kathy today. I am about to really just, I'm going to do this thing just to frustrate her. And I'm like, he's not doing this to you or to frustrate you or make your day hard. Like, he doesn't feel well, right? He just doesn't feel well. And again, he is trying his best to do all of these things and meet expectations for stuff he shouldn't be doing right now, right? For all intents and purposes, he should probably still be baking, but I have failed him, right? And so now he's a bad kid. He's misbehaving. He's being bad. And it just made me think about this idea of misbehaving. It just feels really intentional, right? Like failing to conduct yourself in a way that's acceptable to others. I don't think that he did it on purpose. I think he didn't feel bad, but then it made me feel bad because he was a bad baby. He was being a bad kid because I had failed him, right? So we're going to move on to my least favorite word in the world to hear in the NICU, really anywhere else, but in the NICU specifically, because I don't know what it means, right? This idea of being difficult, what difficult families are. So in my previous role, I went around a unit one day and I just asked a bunch of people different job titles and whatever they were doing, like, what is a difficult family? Like, what does that actually mean? And so some of the answers that I got were that difficult families were the ones who don't show up, the ones that are always there, the ones that don't trust us, they ask too many questions or they don't ask enough questions. They never try to build rapport with the staff. They're not compliant. They're always questioning everything we do. They don't listen, or the ones that are writing down every single thing that we're saying because, like, why are they doing that? Like, they're listening too much. And I just remember thinking after that, so in order for me to be a good parent, or at least just not be difficult, I need to show up just enough, blindly trust strangers with my child, ask the right number of questions, be willing to listen, but not listen too much, and adjust all of these things depending on who I'm interacting with, because I don't know what it means to them, and I want to be good and not difficult. But I know for a fact, like thinking about all of this, that I was a difficult parent. And I know that I was difficult because I was hyper vigilant about everything. But I don't know if people ever thought that, like, oh, she's being hyper or hypo, whatever. And that's really just a trauma response. Like she's just in trauma and she doesn't know what to do. Yeah, but I think difficult is just like a cooler story to tell about people, right? Instead of something that maybe we can help support. And then last but not least, is like the absentee, disengaged, inattentive parent, right? So like I said, G was in the hospital for 268 days, and I was there every single day, except for this 10-day span because I had gotten really sick. I ended up with strep throat. It was a whole production. I had to get my tonsils taken out. It was ridiculous. But I wasn't there for 10 days. And in that 10 days, this really, really interesting thing happened where I became a bad parent. I saw these two notes. So I have a copy of Gavin's medical records from that time. And there are these two quotes that stuck out to me. The first one said that the patient was having a lot of DSTATs today, mother absent. And then the other one was patient had a good day following acute sickness, mother never here. And everyone I thought knew that I was in the hospital, right? I wasn't just not showing up because I didn't like my kid. And I was just like, ugh, over this NICU baby. Like I'm done with this whole project. But I was sick, right? And then the reality was that up until the day that I got sick, I was there every single day. Like I never left. I hadn't slept in my bed for like 152 days at least. And I actually stopped being a good mom to my daughter because I didn't see her because I was always at the hospital with her brother. So the idea that I was absent or non-existent or unavailable felt kind of like a stretch to me. Plus, his dad was there every single day. Like he was there every day. Gavin was not abandoned. He was not neglected. He was loved beyond love. But I was an absentee parent because I had gotten sick. So I just want to talk really quick about like good versus bad, right? So the good parent, it's a really loaded label to wear, especially around medical professionals, because it doesn't really feel like a fixed label. And it seems really fickle and not really attached to any realistic expectations for somebody who is in active trauma, which I think every NICU parent, regardless of how well, we think that their kids are doing, they are in a trauma space. So if you want to be good, you have to be these types of things, right? Gracious, courteous, kind, pleasant, invisible, because showing up as your full self might make somebody uncomfortable. You have to be accommodating. Understand that people are going to make mistakes. You shouldn't make any mistakes, but other people will, and you need to be accommodating and accepting of that, and be present, but not too present, because we already talked about that. And if I think about all of these things, again, I wasn't a good parent, right? I wasn't good because never mind being my full self, I couldn't access my best self most days because he was unstable and I was emotionally dysregulated. And that combination doesn't feel good to me. So I don't think that I was a good parent by a lot of the standards, right? But then you think about what bad parents are, right? So when we don't meet your expectation of being good, then the language switches and this bad thing happens. And the bad label feels a little bit more fixed, right? It's not permanent, but it's definitely like attached to you with some sort of like super glue or like something just really really attaching, right? So, if you're not gracious, then you can be like labeled obnoxious or disagreeable, or if you're not agreeable, then you're demanding or God forbid aggressive or intimidating. Like you're trying to juggle all of these things because the last thing that you want to be is overbearing or difficult. And we think about it, it's like, oh, well, it's just stuff that we say, but it's not just words. Like these are the things that show up in your child's medical chart, right? And you can't really outrun those words or the stories that people will think about you because of those words. So now I'm going to talk to you guys a little bit about some of the things that I believe are barriers to effective communication. The first one is intentionality, right? So like Paige talked about, did the 28 or 29 weeker in my case who didn't extubate, did they really fail that extubation, or do they just need more time to grow, right? Thinking about saying what you mean and meaning what you say because of the impact that it really might have on someone. When you come into the room and you need to talk to me about a course of treatment, is your intention in that space to convince me or inform me? Because the way that you communicate, depending on what your intention is very, very different. Like, do you want me to just blindly follow this course of treatment, or do you actually want to help me understand what's going on, the diagnosis or whatever we need to address, offer a treatment, and then understand what scares the hell out of me about all of the words that you just word vomited at me, right? Because while you're like, well, it's not a big deal, it's just a G-tube. We do G-tubes all the time. I don't, never done one, don't know what that means, right? So is it okay that I'm scared? Because I am, because all I heard is surgery, and that scares me, right? And so I think, a lot of times we get wrapped up in our intentions and we say we had good intentions going in and we don't understand why that parent reacted that way. But when your intentions are out of alignment with the words that you say, the impact is always going to be the most important thing, right? So that's the thing that we have to be accountable to. If that parent is not receiving what you're saying, then that's what has to be addressed. It's not well, I went in, I didn't say anything wrong. Well, something happened, right? And so we got to figure out what that is. I always think about my grandmother used to tell me, because I was her favorite, and I was never in trouble, but she would say, listen, I'm like, well, I didn't mean for that to happen. And she's like, the road to hell, baby, is paved with good intentions. Like, I know you didn't mean it, but that's what you did. So we got to talk about what you did and what, how the other person felt. So intentionality is really, really important. The next thing I'm going to talk to you guys about is sympathy, because I think that a lot of us are socialized to be sympathetic. And I think that sympathy is it's cool, but it's an interesting thing when it comes to effective communication, especially in trauma situations, because it's this thing that we do when we try to walk in someone else's shoes, right? In order to understand what they're going through. But the dangerous thing about that is it really unintentionally minimizes my experience and makes it all about you and your experience of my experience, right? So there's this, I guess it's a special where with Brene Brown, I'm pretty sure a lot of people have heard of her, but it's an HBO thing, and she talks about sympathy, and she says basically that you can't walk in the shoes of someone who doesn't share your privileges around certain things like education, class, race, access to resources, privilege, or power, right? And we all know that there is a really big power dynamic that happens in our NICU spaces. So when you try to walk in the person's shoes, many times you end up causing harm or pain, which leads to disrespect or mistrust. Like, it just turns into this thing. So like for me, trying to walk in my shoes is when every time someone would come in and say, trust me, I know how scared you are. I totally get it. And I'm like, well, do you? Because like, when is the last time this happened to you? Like, when was the last time that you had to sit and watch your baby code, or and you had to trust total strangers because you were completely worthless and helpless in this situation? Because that's how you feel, right? I can't even help my baby. Like, when was the last time that happened to you? So do you, like, you don't get it, and it's okay. I don't need you to get it, but stop telling me that you get it. Or, a time where I had somebody say, I know how scary this is. I was terrified when my dog had to have surgery. Please get out of my shoes. Like, invite yourself out of my shoes, because I promise I don't need you to walk in them, like, to do this thing with me. Sympathy is the thing that we are often doing when empathy should be where we're at, because that's the actual gateway to compassion. And that leads into the next barrier, which is my favorite, because listening is hard, right? Listening is hard, and it's a two-part process. And I think that sometimes we get lost in the sauce of it, because we think that we're doing this really great thing. But listening, the first part of listening is hearing with humility, right? It's recognizing, like Paige said, like, we are having a shared experience, and I'm not going to discount that. We are both here, and we are both caring for this child. And that patient of yours is my actual child, right? You are also at work. You are doing this thing that you have trained for and prepared for, and this is your norm and your everyday. And I am in hell. Like, it is a special kind of hell. They have run out of water. I am swimming and drowning, and I'm mostly just drowning because my baby, my child, this human that I love beyond like any comprehension, is sick or hurt. You've told me how much that, like, they're suffering or they're down, like all of these things. That is your patient, and that is my child. And we are not having the same experience. It's not the same thing. So hear me when I say that I am scared or that I don't understand, even though you've explained it 100 times. Just hear that I don't get it, and I need you to help me get it. When I say that I'm angry, create space where that's okay, and just hear me and meet me where I am. Judgment-free zone. All NICU should be a Planet Fitness, like, no judgment. We're just here to support, right? And then the second part of listening that gets really hard is believing families, right? Oftentimes, that's the reason that we get called to task for not listening, is because we don't believe people, because what they're telling us is their experience in their shoes doesn't reconcile with our experience, right? It doesn't mesh with my experience of myself and who I know that I am. So you can't be having a bad experience of me because I'm a really great doctor. I'm a really great nurse. I'm the best OT on this team. So that can't be how you're feeling. This unit is amazing. Look at all the awards we've won. You can't be having that type of experience. But I am. So if you ask me, hey, what's wrong? What's going on? How's it going? And I tell you that I feel ignored or overlooked or dismissed, and I'm angry and my heart is broken, I'm sad, or I didn't have a good talk with this person. If you ask me and I tell you and you dismiss me, communication has broken down, right? Because now I don't even trust that this is a space where I should be talking, where I should show up. And so I stop. Last but not least is storytelling. And again, we tell powerful stories in the NICU. We tell stories in the hallways, in patients' charts, during handoff, workrooms, during rounds, right outside of people's doors, like the walls are soundproof and they are not. We tell these really impactful stories, and they're impactful and they're powerful because of power, right? Stories are defined by power, how they are told, who gets to tell them, when they get told, whose stories and how many, all these things. So the quote on your screen is from this TED Talk by Chimamanda Ngozi Adichie, and it's called The Danger of a Single Story. And I really wanted to share because the most dangerous thing about the stories that we tell about families is that they're singular, right? There are no three sides. There are barely even two sides sometimes. It's usually just whoever that person in power is. It's their perspective, their lens, their power gets to tell the stories of families. My story. And there's so much harm in that because your truth of me is not the truth. It's just yours, right? So before I get into how we can deliver some hope, I really wanted to share this quote because I think it's like so amazing. But when you think about compassion, it actually just means to suffer together, right? And among a lot of emotion researchers, it's defined as a feeling that arises when you're confronted with another person's suffering and you feel motivated to relieve that suffering. So if you think about the power that you have, the power that we have in NICU spaces, right? In our darkest moments as NICU parents, as NICU families, and they are aplenty, the dark moments, we are relying on total strangers to feel motivated by our suffering, our pain, our sadness, and actually act to relieve it, right? So how do we go about doing that? How do we go about delivering hope? How do we get to hope? And again, these are just my thoughts, right? So for me, it's about language. Language is the first way that we foster hope. Language, words, our ability to communicate, like these are the most powerful tools that we have because regardless of who we are, where we come from, all the things, we use language in all of its forms, be it verbal, body language, visual, whatever it is, we use it to express our thoughts and our feelings to others. So when we are abusive or we are arrogant with our words, that's how trust is broken. If you're flippant or dismissive, when you're disrespectful with your words, right? Especially for people in power, like that is how we obliterate trust. One of my other favorite quotes is trust is lost in buckets and gained in drops, right? So if you think about it, one word can throw out gallons of trust, just toss it right out the window because that's the power of words, right? So I just think it's really important for all of us to just take inventory of our words and think about it. Pause for a second, right? Pause for the cause and just think because, like I said, when words fail, if you ask me and then you dismiss me, when words fail, disease can set in. And sometimes the disease that we cause with our families is incurable. And that's not safe for us. It's not safe for the baby. It's not safe, period. This idea that words are not good or bad on their own is like one of my favorite things in the world because if you think about it, right, a word like positive, we all hear positive, we're like, yes, it's a good thing, it's so incredible, we want things to be positive, unless it's a COVID test. Positive doesn't feel great when you're talking about a COVID test, right? Or like having a positive blood culture, context is everything, right? When it comes to communication. I don't know that for us, when we're in active trauma spaces, I don't know that we're taking things out of context or if we're just processing with the tools that we have, coupling that with whatever explanation we think you gave, right? Like it's a hard place to communicate if you don't provide really great context. And oh no, sorry. Communication is actually the key to everything, right? And so context provides meaning to messages and helps to avoid miscommunications, because miscommunications for me leave way too much room in the imagination. And I feel I actually felt bad for anybody who was stuck in the imagination of me when I was in the NICU, right? Because tired, stressed out, hungry, hangry individuals, like that imagination is a space to be in. So just thinking and being more careful about our words and the context that we use. And then last but not least, right, stories. All right, I'm gonna get through this and I'm not gonna cry and I'm not gonna look at Malachi's face. So here we go. Okay. Hope is this feeling of expectation, right? This desire for a thing to happen. It really is just a want for something to be the case, right? And so on April 12th of 2009, after a miscarriage and a stillbirth, I met somebody who changed our entire family forever. He was a pound and a half and he was so amazing. But the stories that were told to me about him for so long were the worst stories ever written or told in my mind. Because, and not because they were like hard stories to hear or because at times they were sad stories, but because a lot of times they were just devoid of hope, right? All I heard from the day after G was born is how he would die. I heard how sick he was, how he had continuously missed the mark because he failed all these things. I heard stories about myself that I was delusional or absent or a bad mom whose, quote, unwillingness to listen would cost the patient his life. That is one heck of a story to hear all the time, right? A better story, I think, is that I, like many NICU families, our NICU troops, I was trying and I was doing my best to navigate this space and this place with no GPS. I was navigating this trauma tornado and I was tethered to the world, to that space by this single wet angel hair pasta noodle. And there are gale force winds and there are bears and the bears have knives. Like it's a whole thing, right? That is what I was trying to navigate. And so I think that story, right? To hear that story and understand that I was doing my very best to do a thing that you get to do every single day and you're so excellent at it, but I'm not. I wasn't trained and I wasn't prepared for it. We have the power to change the narrative, right? And encourage people and give them hope that regardless of the moment that they're in at that time, that it's gonna be okay, whatever okay means. And we get to define and redefine what okay is, but without compassion and empathy, intentionality to our language, listening, hope is really outside of the grasp of any of us. And we can't do that effectively. So, okay, as I close, I just want to say from the day that I found out that I was pregnant with G, and that's honestly the first picture that they ever took of him. And it's still one of my favorite pictures in the world because he was holding that ET tube because he knew he was going to pull it out every chance he got. But from the day that I found out I was pregnant, I had so many hopes and dreams for him. Regardless of all the stuff that had happened before him, I still had hope for him, right? And then overnight, he had a stroke and a grade 4 IVH was the result of that. And the language that was used to talk to me about my baby the next morning absolutely destroyed all the dreams that I had for him and offered me no hope, right? What it did, what that story, what that fellow did was he sparked fear and he created tension, which led to mistrust. I think about it all the time and I know that he didn't mean any harm. I know that he did not, but he really did cause it. And a lot of times I think if our foundation to our relationship would have been different, if he would have just said to me like, Mia, listen, we need to have a really hard conversation. And some of the things that we're going to talk about might be hard to hear, but I really want you to have all the information so that you can make the best decision. You and your family can make the best decision, right? And then he still told me all the things, because the things that he said he needed to say, maybe without some of the certain death pieces, but he could have said what he needed to say and then say, like, whatever decision you all make, we are here. We will do everything that we can to support you, everything in our power to get you to the outcome that's best for your family, right? You'll take however much time you need. We will be right outside, answer any questions, whatever that looks like. He still could have given me all of the facts in a way that didn't lead me and my family, and specifically my father, to believe that they wanted to kill my son because they didn't have any hope for him anyway. I know that hope sounds like a small thing, but for this scared mama, for this NICU mom, it would have been everything if someone could have just thought enough about me and my family and my son to give us hope in that moment. So that is all I have to say. I am done talking. Thank you guys so much for your time, Malathi, Morgan, everybody, for inviting me to do this today. And I didn't cry, so I am doing great. Thank you so much.
Thank you so much, Mia, for your bravery and your vulnerability. I think, looking at the chat, everybody is very deeply affected by everything that you have to say and the very important points that you bring up about communication and providing hope. As a former NICU parent myself, I really do attribute a large portion of my, I guess my ability to advocate for my son to one single neonatologist who encouraged me to be an advocate and ask questions, regardless of how maybe some other folks in the NICU felt, some of his colleagues felt. And I truly believe that he changed my family's course with one single interaction. So, it's not just that, the negativity that has an impact, but also, as a singular physician, you can have a huge positive impact. There really aren't any questions at this time. Kira, do you have one?
Well, I just wanted to again reiterate what you said, Morgan, and just thank you so much, Mia, for sharing. And it's it's so hard to hear that this happened to you, and I'm just so very sorry. And I thank you so much for the advocacy work that you do and the teaching that you're doing, so that we can do better. Because, like Morgan said, really, I know we're kind of focusing on what not to say, what not to say, or whatever. And there are ways to reframe it. And it is, just one person can completely change your perspective or your experience in a positive way as well. And I'm just wondering, Mia, did you have any of those experiences at all?
Positive experience. Yeah, we had tons of positive experiences, right? I think that it's like, when you put up like a tweet or a post and like you have like thousands of comments, but you always find the negative one and it like sticks.
Oh, sure.
And it sticks to your ribs differently.
Yes.
We had a million. Like one of my favorite nurses to this day, she is one of my favorite human beings. She's the one who first told me that I could hold Gavin. Every time I saw her, she was just like, all right, come on, like you get to be his mom. I'm not his mama. Like go in there and go change a diaper because you need to know how to change. I'm not coming with you to change diapers. So get on up. Come on, we're gonna change diapers today, right? But just people that empowered me and saw me and saw how scared I was, but still encouraged me that like, hey, you get to be scared and you can still do this. So come on, right?
Yeah.
Like it was all of those things. I think that the way that we see or don't see people is really, that's really the thing, right? Like,
yeah,
I know when I'm being tolerated. I know when I'm an afterthought to you. Like, I know all of those things. So, if that baby is the most important thing in the room, I shouldn't be too far behind because, hello, going home with me, right? Like, so I
Mhm.
just think that I had tons of great experiences. The 268 days that we spent there were not, they were the best and worst days of my life, right? Um, every time he had a successful day or I had a great day, when I had a APN and she looked at me after rounds and she could see that I was just like in the sunken place because it was one of those rounds where he was just nothing was good about my child, right?
Mm.
And she turned around and she looked at me and she said, "Hey, his electrolytes look amazing. So, you know what? We're going with good electrolytes today." And we are doing good because he's got good electrolytes. And she just saw me enough to say, she needs something else from us. This was a lot.
Mhm.
And
Right.
it's those moments that you just appreciate and those stay with you too. It just sticks a little bit differently, right?
Oh, sure.
Yeah.
Absolutely. Absolutely. Thank you so much for sharing.
Jess, you have a question?
Oh, Mia, I was like hustling through the hospital, excited to hear this talk. I told the nurses, only call me if something's on fire. No, I was kidding. But no, you and I, we connected through Birthing and Magic Collaborative. And I heard you say something. And right after that, I went and wrote a LinkedIn post talking about the wimpy white male and strong Black female and how those narratives run through the NICU. I remember the first time I heard it, I remember thinking like, who's about to pop out here and fuss at us for saying something like that when I was a medical student. And I just really want to say thank you for sharing your stories because, when you're young and you grow up and you say you want to be a doctor, these are not the things that you're taught. This is not the stuff that you see until you show up on rounds and then you're like, right? And then you see it, but then you don't talk to necessarily enough families in this way to lend voice to their experience. And so when I heard you say that on the through a talk we did with the Birthday Magic Collaborative, I joined this NICU moms group and I started to just get curious about people's experience. And my inbox and stuff was flooded with comments from families who shared both things, like things that were said to them that you're like, somebody said that to them in the NICU. And so I appreciate you for that because it's just showing me that these are realities for families. And this is why we need to do better. And we need to share, like, your presentation needs to be like part of an orientation. But also I'm speaking at the National Association of Nurses, and I'm talking about cultivating compassion. And so you may see me borrow something from your talk in terms of sharing how this is important, like how we show up, because what I said, I wanted the nurses who hear me talk, what I want them to do when they show back up to work the next day is to know that I have power in the actions and the words that I do when they, like you said, when they're going to scrub their hand and it's just a job. This is a family's lived experience right now. And so how can I show up today? Like, what's one thing that I can say that's going to move this family forward in the best possible way? So I just love how all of this is coming together. So I just wanted to say that, and I'm just so happy to be here. I'm sure you could tell, but thank you all so much. This is just such a beautiful platform. Thank you.
Thank you, Jess. Yeah, and welcome again to our executive council. We're really happy to have you. Mia, I think well, I know there was more than one person who put it in the chat, but to echo Jess, your talk should be given in every NICU. I do think we have time for one more question. Sue, would you like to go ahead? Chaplain, if you'd like to send it in the chat, we can ask Mia to respond after the presentation.
Thanks. This is Sue Bowles. I just wanted to say thank you so much. And I wanted to let everybody know that I've been so blessed because I've worked with a neonatologist named Tony Orsini. Many of you have heard of him. He is going to be speaking at NAN this year, but he has written a fabulous book called Breaking Bad News. And in that, he gives us lots of strategies of talking to parents, things like sitting down at the bedside when we talk to them, not standing over them, being there for them, all of these things. And he has had such an impression on me in the NICU. And Mia, listening to you and what you went through, I'm so sorry. I just, I wish everybody would go through it. Tony's whole thing in life is making sure that people know how to tell people things and tell them in such a way that we can help them. And I just wanted to let everybody know the book is out there. It's been reviewed by NAN and they really recommend it. So it gives us a lot of good strategies. And that's something we don't always get. We hear all these things. We know what we're supposed to do, but we need the education on how to do it. And that to me is something that we miss a lot of times in our medical education. So please, 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 if you're interested in that, take a look at what Tony has to say and take a look on how we can do better for our families. And that's all I wanted to add.
Thank you, Sue. I'll be sure to send Tony's book in the follow-up email with the webinar recording and all of the resources that were shared in the chat. I want to say thank you again so much, Paige and Mia. Incredible talk today. Again, this recording will be posted on our YouTube page and on our website, and I will be sharing it in a follow-up email. Please stay tuned for our next webinar, which is on September 12th. Be sure to follow us on all of our social media platforms. And thank you for your commitment to family-centered care.